So I'm now going to ask Akiko Maehara to talk about clinical and anatomic scenarios where IVUS is still the gold standard. Akiko?
Thank you. Let me start. My talk is more practical and clinical anatomical scenario where IVUS is still gold standard. So those are the scenario where the IVUS is very important. And let's go through. What is the most important is left main, and both case it's clear left main disease, and left hand side is a little bit unclear. And when we open the IVUS, it's quite different mechanism, and the left-hand side is very severe calcium, and the right-hand side is actually very negatively modeling. So understanding of the disease is very important, and that IVUS is gold standard. This is a case that distal left main was treated 111 and cured stenting, and looks like okay at the end of the procedure. However, the patient is coming back 2 months later and non-STEMI, and you can recognize osteocircumflex having some thrombus. And we look into the IVUS. This is how it looks like an index procedure at the end. This is now. And what we see in the osteocircumflex was first underexpanded, and second, there is no stent strut at the carina side and dissection. So that's giving us this organized thrombus. So it is quite important to check how it looks like at the end of the procedure to eliminate this type of the complication. So this is how it looks like in the DK clash. After the stenting into the circumflex, we can check the wire position from the LED pullback. You can see the circumflex wire here and here, and we can easily recognize where the wire in the longitudinal view. So whenever we do the two-stent technique, the wire has to be proximal portion. In the previous case, probably wire is too distal, making such complication. So after the stenting, what's happening? This is a case from the circumflex to the left main. Only one stent was implanted, and we can see double layer or multiple layer the stent at the ostium. This is so-called stent deformation. Many times happen in the ostial left main. In the Excel trial, it is not layer phenomenon. We see 6.5%, and the majority was left main ostium. And if the patient having the stent deformation, they have poor outcome, even the MSA was corrected. And Osteolegia is very important to do the IVUS as a gold standard. And this is a case, you see the relatively normal distal portion, but proximal portion is very focal calcified osteolesion. And after the stenting, we thought we finished. However, it was not. And stent was implanted more distally, and osteal right coronary artery was totally missed. That recognition is quite important. And this is really gold standard to do the IVUS. And how looks like this instantly stenosis at the osteal right coronary artery. As previous speakers spoke, this is quite vulnerable place. And we look into the cause. And we confirm the stent was actually well covered ostium, and the stent was actually well expanded, and actually no fracture or deformation. And really ended up, the main reason was really negative aplasia. So understanding of what's happening in the osteolesion is IVUS is really gold standard. And how about this case? This patient having the proximal LED, and after the balloon, we see the acute occlusion. So in such scenario, we have to understand this is due to the mechanical cause or due to the distal embolization. In such, because already we don't have flow, OCT cannot do, and IVUS is really the gold standard. And what's happening in this case, as dissection extended distally and big intramural hematoma pushing to the lumen. So when we recognize we have to put stent from here to here, that's making very clear. So what about this case? Also, the IVUS is gold standard. This is a patient 55-year-old woman in the STEMI. And after the wiring, we thought this probably atherosclerotic STEMI, but we have to do the IVUS to understand what's happening. And we did the IVUS, and actually this is SCAT. and very proximal, and this side is so normal, and in the middle is all intramural hematoma. It was due to the scat. And very important to understand the mechanism of this disease. And then this has to be by IVUS, because if we flash, which making worse and worse, and this is still IVUS is gold standard. How about this case? This is a CTO in the proximal LAD. You see the occlusion in the proximal LAD from here. And I do believe many people thought proximal cap could be here, but we have to check the IVUS. And we did the IVUS from the remus to this portion. And we recognized occluded LAD and also the possible blood speckle. And actually, the proximal cap is not here and actually here. And this is how it looks like the final after the stenting. So recognition of the proximal cap by IVUS is really gold standard. And reverse cut is also very important using the IVUS as a gold standard. You can see the CTO in the proximal right coronary artery. After the overlap of the wire of the retrograde antegrade wire, we check. And we recognize retrograde wire is intraplaque and antegrade wire is in the subintimal space. This is really the worst scenario of the reverse cut. And we really have to rewire this retrograde wire into the subintimal space. And IVUS can recognize this very simple four pattern of the antegrade and retrograde wire. And as I show this pattern is the worst scenario. When we see this pattern, most of the time I never seen this reverse cut is successful. It's really you have to redirect the wire. And IVUS is really gold standard to recognize this type of the pattern. And this is a different CTO in the mid-LAD. And after the antegrade dissection re-entry, we recognize the true lumen was collapsed. And I saw this could be the true lumen, but you see the some tissue, and we push more, and we see the true lumen completely. So recognition of the true lumen at the end of the procedure of the CTO wiring is quite important. This is really only IVUS can do. And this case was different. It's very diffuse LAD lesion. We have almost no idea what's the vessel size. And OCT is a little bit tough because we could see only the lumen, such diffuse disease. And we performed the IVUS, and we really surprised and proximal to distal and how big the vessel was. And very distal is 3.0 and proximal is 4.9. In such disease, IVUS is really gold standard to evaluate the vessel size. And finally, this is a clinical scenario which IVUS is gold standard. And this patient was renal insufficiency and having the diagnostic angio, we can do the all procedure without contrast. First, the operator put the wire into the main and side branch, and using this marker, we can recognize how big the vessel was, and 2.5. And after the stenting, again, we perform the IVUS and confirm the minimum stent area. So to summarize, this is a conclusion. This is a scenario where IVUS is really gold standard. Thank you.
Excellent, Akiko.